West, and other folks that I have done some capacity building and technical assistance with. So if you want to jump to the next slide. So we'll just go through real quick what NASTAD is and who we work with, right? So NASTAD is Science of State and Territorial AIDS Directors. For a lot of reasons, we don't use this anymore, in that we work in more than just HIV. We work in hepatitis and drug user health now as well. But basically, we're a national nonprofit membership-based organization who are also capacity building providers, just like New York City SIBA. But we focus our membership base within the HIV and viral hepatitis programs of all the US states, CDC federally funded jurisdictions, and all the US territories. So we basically get to work all throughout the country, providing all kinds of technical assistance, state level advocacy and national level advocacy with funders, social justice, and all kinds of just different types of technical assistance and sort of troubleshooting with state programs to improve services. Specifically, I'm in charge of the drug user health program here, which is a relatively new program. But NASTAD has been supportive of drug user health efforts and SSPs for a really, really long time, but only recently have we incorporated it as a newer program. So if you want to go to the next slide. So here's sort of the quick rundown of all the things we're going to try and cram into a half an hour. But overall, we're here to talk a little bit about the intersection of HIV, hepatitis, and drug use across the country, why this intersection is so, and its response is so complex, how that feeds into a really complex funding landscape for syringe service programs, and what funding and sustainability can look like for programs. So if you want to go to the next slide. So I'm sure this is not news to any of you, but some people always wonder, like, why does NASTAD, who works in HIV and hepatitis, also work with people who use drugs and drug user health programs, right? So here we see, oh, if you want to go to the next slide. So here we see why, right? So we know that nationally injection drug use still accounts for about 9 to 10% of the new HIV cases. Increasingly, 65% of hepatitis C cases that we know about, but we also assume that that number is increasing. Among people who inject drugs, each year about 20 to 30% of those folks acquire a new hepatitis, incidence of hepatitis, a new infection, and about 60 to 90% of folks who have been injecting drugs will have hepatitis after about 5 years. There's a really high comorbidity between the two as well, right? So among people who inject drugs and have HIV, about 80% of those folks, oh, I'm sorry, this slide, 75% of those folks also have hepatitis, and among people with HIV who do not use drugs, comparatively, only about 25% of those folks have hepatitis. And we know that these infections are really super expensive, right? That each case of HIV that we can prevent, or each case will cost us about 400 grand in terms of lifelong care. We know that hepatitis, it's even hard to kind of break it down in terms of like each individual case, that if we were to treat basically everyone in hepatitis who has hepatitis C in America right now, it would cost us about $100 billion. And if we did that, we would still save over the next 20 years about $78 billion. So treatment for hepatitis is really cost saving. If you want to go to the next slide. We also know that hepatitis C is the leading cause of death in America among all infectious diseases. Right now, the CDC estimates about 41,000 cases of acute hepatitis in 2016. Most recently, 204 million people. Those are the most recent estimates from this year about how many folks have hepatitis in the US. And we also know that the injection drug use is currently the most common risk factor. This has transitioned over many years. It used to be, sort of a baby boomer population, but we're seeing those incidence curves really trend towards injection drug use as being sort of a key factor here now. And we also know in terms of outside of infectious disease that, there's all these other bacterial and soft tissue infections that are also incredibly, incredibly expensive and onerous on our programs and really impact the quality of life and health of the people that we work with. So you see them kind of listed on the left there. So if you want to go to the next slide, about this time last year, actually exactly about this time last year, the CDC put out one of sort of the first studies that they really did this overlap, that really correlated increased injection drug use behavior with treatment emissions is the criteria they were looking at, treatment emissions for injection drug use, specifically for opioids. And the numbers that we see here are really, really staggering. Among very young folks, the 18 to 29-year-olds, there was a 400% increase in acute hepatitis and an accumulated about 700% increase in treatment emissions for opioid use disorder. And among the age group right above that, you're really seeing 30 to 39-year-olds, a total 325% increase in acute hepatitis and about 130% increase overall for treatment for injection of opioids. You know, and you'll notice that the little image on the side, and I often think like, geez, you could just put the overdose death rates and, you know, the images that we see, those graphs that as they progressed over time, and you would see a pretty clear overlap there as well. So next slide. So nationally, you know, a lot of the a lot of the dialogue around infectious disease consequences related to injection drug use behavior really kind of kicked off. It really, you know, that flame kind of got lit when there was one of the first outbreaks that we've had in America, and the largest, I don't know if it's still the largest, I think it might still be the largest to date, but there was an HIV outbreak in Scott County, Indiana. Scott County is a county of about 24,000 people. Specifically, this outbreak was in Austin, Indiana, which is a much smaller town, a town of about 4,200 people. The outbreak occurred in 2015. Over the first 6 months or so, they identified about 120 different cases of HIV. And to date, there are about 232 cases of HIV. In the decade prior, there had only been 5 reported cases. So just really, I mean, astronomical, staggering number here. The outbreak was quick and severe and intense, right? And in terms of co-infection, we also see that right now, 92% of the folks who were identified as having HIV related to this outbreak also are co-infected with hepatitis. And on the right here, what we see is actually the epi investigation. So they're not dog chew toys. They are, you know, these are the webs of people who were sharing risk factors related to either injection drug use, sexual behavior and injection drug use, or sexual behavior linked to someone who is injecting drugs. And so you just see, if we were able to zoom in, you would really see that all of that dark area between the 2 ball-looking ones are individual lines of shared risk factor. So really quite frightening. And part of the reason that I really bring up Scott County, and I'm going all the way back to this sort of history, is that after this, this is really what sort of sparked more of the national conversation and really prompted legislative action in terms of changing policy around what, changing policy in terms of using federal funds to support elements or parts of syringe services programs. So just to give you some context there. And if you want to go to the next slide. So, you know, after this outbreak happened, you know, the CDC came in and they helped do this epi investigation. And they also were trying to figure out, like, wow, like this was severe. And so what was it? What were the key things that really led to such vulnerability in Scott County in Austin, Indiana, right? And so there was a study done that's now being replicated in many, you know, on a smaller scale in many states and jurisdictions across America, but a study done about, like, what were those particular vulnerabilities and risk factors? What did lead Scott County and Austin to be just so vulnerable to this kind of outbreak? And how can we help communities figure out what those things are moving forward in the future? And so they developed criteria, things like poverty, homelessness, lack of education, unemployment, lack of behavioral health services, public health services, and lack of SSP infrastructure and syringe services infrastructure, right? And so what they did was they identified the top 220 counties in America, right? And which those are all the green counties in America. And usually I ask people, like, how many counties do you think are in America? And it's wild, right? 220 is only the top 5% of counties in America. There are about 4,000 counties in America. So, you know, sometimes people will look at this map and be like, oh, well, you know, we're not on there. We're good. But really, I don't know how you'd feel if you were in the top 10% or the top 15%. You know, this is just the top 5 counties most vulnerable to an outbreak identical or similar to the one experienced in Scott County. And so another thing that people will usually notice is, well, like, why is San Francisco not on here? And why is New York not on here? Why is Seattle or New Orleans, Houston, places that have had historically a longer history with injection drug use? How come those folks aren't exhibiting a certain vulnerability, right? And if you want to go to the next slide, it was really kind of one of the key takeaways of sort of some of the CDC research, actually, is that one of the biggest protective factors for communities in terms of preventing a hepatitis and HIV outbreak was actually the existence of pre-existence of syringe access programs or harm reduction programs, right? And I think everyone on this call is quite familiar with them, but obviously, just to run through it, we know they're the most effective way to prevent infectious diseases for people who are using drugs and injecting drugs. They've been shown to not increase drug use or crime within the communities in which they exist. And that we also know that they're a really good avenue to engage people in care, both for behavioral health and also other sorts of health care, right? So, I mean, here we see in this map, it's sort of an opposite. The pink are now the vulnerable counties, and the SSPs are the green dots. And just of note, all the SSPs that are kind of in the Appalachian region are, I won't say all of them, but I would say 95% of them are new since this study was done, right? So just quickly, if you want to go to the next slide, it's also, it's not just about infectious disease. When we think about those other criteria that they studied and included in that study, what we're really talking about is social determinants of health. We're talking about environmental things like poverty, employment. We're talking about, a much bigger, broader sense of health. So if you want to go to the next slide, I threw this one in here because this is sometimes how I like to visualize what some of those social determinants are, really. This is what, this is an ecological model where, the biggest blue circle really is those big, umbrella structural things like racism, stigma, poverty, the big social determinants. And then it kind of goes down, into what is eventually just, the person and what they present it with, so then we have housing in the bubble below that, availability of alcohol and drugs, the different types of things that are present in community, community supports. Then we have sort of a personal substance use history, tendencies, mental health, and then sort of the person right there in the center. So all of these things and the services that we need to think about are really much bigger than just sort of just bigger than sort of giving one syringe to to a person to prevent just infectious disease. That when we think about public health, we're often thinking about these bigger umbrella things. And so, arguably everyone should be involved and we should be sort of messaging towards that. But we also know that when we're trying to address these bigger things, because that is what eventually filters down to that person and potentially increases HIV or hepatitis risk or overdose risk, all of those services kind of have to be part of a bigger strategy. And that's part of why funding can feel really challenging, right? Because it's just, it's a lot to address, right? If you want to go to the next slide, I just, throw this in here because I think it's important to remember that we all know drug use really happens on a continuum, right? And that continuum doesn't really always happen in a linear fashion. In fact, most often it doesn't, right? So at the bottom, you sort of see what you think of as being the components of a continuum, sort of experiential, social, ritual, binge use, any of these things. And as children or even as adults, we're kind of taught that drug use happens in an upward straight trajectory of an arrow, like it is on the left. And that's just really not true. Most people will use drugs for a variety of different reasons in a variety of different contexts. And it's just important to remember because, we sometimes think about people who use drugs as looking a certain way or being able to locate folks who use drugs in a certain way. But really, people are using drugs everywhere along this continuum. And especially for people who are injecting drugs, there are risk factors that we could places where we could really target our services at every point of this continuum, right? And that's tricky too, because then our services and the funding for them really need to match that diversity. If you want to go to the next slide. So I just throw this one in here because you know, sometimes I think about nationally, when we think about funding in particular, you know, you hear politicians talk and all they really talk about is either, you know, well, we have an opioid crisis, people are starting to inject drugs more than they used to, and so what should we do? Well, we should fund prevention and treatment. And the prevention that those folks are talking about are typically only prevention of use initiation, thinking about stopping people from using drugs in the first place, and then treatment. Treatment like medication-assisted treatment or behavioral health treatment. And we know that there's a really big range, a gray area there, that once they pass that prevention net and they've started to use drugs, all the people in that gray range are actually the folks who are at highest risk for contracting HIV and hepatitis and dying of overdose. And, you know, before they get to treatment and then arguably after. So it's really important for us to understand and have a better perspective sort of hold on how many people are sort of in that gray area, because that's where a lot of public health and SSP programs really fall, right? So according to SAMHSA, the Substance Abuse Mental Health Services Administration, the National Survey of Drug Use and Health, which they do every 2 years, approximately 10% of the US population used drugs in the past month, and that includes marijuana. Over the past year, about 12 million people older than 12 used prescription painkillers or heroin. So 12 million, right? And in that same year, only about 2.4 million total met criteria for having an opiate use disorder. So we're looking at sort of about 79% of the population that are in that gray area, sort of between those nets, or of that population who have used heroin or injected heroin in the last year, right, or opiates. So really, arguably, a lot of our services, you know, if all we're talking about is prevention and treatment from a funding level, that leaves about 80% of the people who are actually at risk for HIV and hepatitis transmission via their injection drug use in that gray area, right? So that's 9.4 million people who are in there, and that's just for opioids, right? You can inject all kinds of things, which many of you know and have experience with in terms of methamphetamine and other substances. So just really important to think about sort of where our funding is being allocated, because it's usually somewhere along the spectrum, either the prevention in that, you know, gray area of sort of what services do we provide for people who, when they need, you know, when they're actually still using substances, and then treatment. And the next slide kind of gives you just a really brief overview of what some of those services could be, the ones sort of in the gray area. So overdose prevention, PrEP for people who use drugs, MAT, mental health services, behavioral health, HIV, and hepatitis testing. All of those things have to be funded. And you'll notice that a lot of the origins for where that money can come from are often from different federal agencies and often employed by different state agencies and provided by different community-based organizations and agencies that focus in different parts of sort of what we think of as a broader public health, right? So trying to lay the groundwork for just why federal funding is complicated, and funding for these programs is really complicated. So let's move on to federal funding first. So go ahead and go to the next slide, right? So just a little history. So since 1988, there's been a ban on using federal funds to support any syringe service programs. They weren't called that back then, syringe exchange, needle exchange. It existed, full ban existed until about 2009. And then we had this like window grace period starting in 2009 when there was no ban, and we could use federal money filtered down to SSP programs for every element of SSP programs. And that lasted for about 2 years. And, you know, I think the majority of the people on this call do work within these programs and are pretty familiar, but we know, you know, the element that stigma plays into this, and sort of, they're not always the most popular programs for legislators to advocate for. So there was a new ban imposed in 2011, a full ban, indicating that, you know, there would be no availability for federal funds to be used for SSPs, and that existed until right after the Scott County outbreak in 2015, and then in 2016, Congress allowed a partial lift of that ban. Now, the partial lift is complicated and makes things a little overly complicated and has felt frustrating for some of us. But, you know, at the end of the day, it's better than nothing, right? So if you go to the next slide, you'll see why it's complicated. So here's the language. And we don't have to read the whole thing, but it basically says you can't use federal funds to purchase sterile syringes or needles for any, the injection of any illegal drug, provided, and here's the caveat, that such limitation does not apply to the use of funds for elements of a program, meaning that you can fund everything but a syringe, and other than making such purchases, if the relevant state or local health department consults with the CDC and determines that their state or jurisdiction is experiencing increased risk, or I'm sorry, is experiencing an outbreak or is at risk for experiencing an outbreak, similar to the one in Scott County, HIV and hepatitis related. So those are two elements there, right? So if you go to the next slide, you can basically buy everything and you can use federal funds within an SSP to support everything except for these two items, the syringes and what we know as being cookers. Part of that is that the state or your jurisdiction has to go through this process, if you go to the next slide, called the Determination of Need process. And this is a fact sheet that was put out by AIDS United. It's a really good little logic model of just what that process is. Basically, you work with, within your EPIs and your health department to collect and triangulate different data points that indicate that you might be at risk for or experiencing increases in injection drug use within your community. Things like overdose death, you could use police reports, you could use hospitalization data, you can use increases in hepatitis, HIV, all of these things. And you basically combine all the data in a certain place, you send it to the CDC and get approved or not. If you don't get approved the first time, they will always send back edits with thoughts about how to improve your application and get it so that you are allowed to then redirect certain federal funds to support your SSPs. So on the next slide, we see that 37 states and jurisdictions right now have completed the determination of need successfully. I see this as a triumphant map, because we're chipping away at this, and we're going to get everyone at some point. So all of these folks, anyone in these states or jurisdictions right now, are able to redirect funds from, and we'll go into the different programs here. On the next slide, you'll see you're able to redirect funds, if you can go to the next slide, from the Department of Health and Human Services, so any CDC money, any HRSA money, and SAMHSA is another big area where you're able to redirect funds. And SAMHSA is allocated most of the behavioral health response money that can still be used for SSPs, right? And it's not just necessarily any money within these, which we'll go into in a bit. There's a lot more specification that goes into that. So more to come. All right, so that puts a cap on sort of the outline of how to use federal funding and sort of what that process looks like. So moving into what SSPs cost, if you want to go to the next slide. So we know that SSPs in general are pretty chronically underfunded all across America. Things have certainly gotten better. There's more and more money and people are being more creative about how to use that money there. But there's I don't know of any SSP that couldn't use more funding, right? Average programs run from, about $250,000 to about $1.5 million. I know from experience, SSPs run on a lot less, and those are often, volunteer run or, run through or they're a small component of a very small nonprofit, something like that. So right now the CDC is putting out some cost estimations. This is a study that they did, based on the idea of an ideal comprehensive SSP based on comprehensive services, staffed 40 hours a week, open 40 hours a week, which we know isn't that super common for a lot of SSPs. And so in the next slide, you'll see just what it is, and you'll get a copy of this, and it's going to actually be published very, very soon, so that's exciting. But they basically tried to categorize out sort of the size of SSPs by annual client volume, being small SSPs are ones that serve about 250 people, medium about 1,250, and large about 2,500. And then trying to figure out the different geographic locations as rural, suburban, and urban, and how that would impact cost. And they basically estimated that the smallest program, so for a small rural SSP, is about $400,000 per year, and that the larger urban largest urban SSP could operate for under $2 million a year. So just keep that in mind, kind of moving forward. They, are intending, hoping that states can use this in terms of guidance and in terms of program planning and implementation, but then also maybe for some advocacy about, just how cost effective these programs are, right? All right, so go ahead and go to the next slide. Because I think it's notable that the CDC, their estimation really was about providing comprehensive services. And in order to get those comprehensive services, we really, really have to think about what the range of those services are, and sort of what type of coordination and what sort of cooperation we need to get there, right? So if you want to go to the next slide, this is one that I tried to make to kind of visualize this, right? Because coordination is really tricky. And ideally with coordination, we would have an integrated strategy sort of at the top, right? We would have everyone who's going to be working with this presentation, an integrated, operating under an integrated strategy, all towards the same, all towards the same goal, and all towards the same, sort of recognizing the different components of their, that they play in that role, in their roles, right? And then that kind of filters down into what we think of as federal funders, right? People like the CDC, SAMHSA, HRSA, even foundations that aren't governmental funders, and ideally all of those people would be kind of buying into this integrated strategy, and then that way we can make sure that that there was equitable distribution of funds for all the different services for everywhere on that continuum of people who are using drugs, right? And then we know that that filters down into the different state agencies that are often quite siloed as well, right? That behavioral health is often siloed away from public health, that injury prevention can be a whole different office, that care for HIV is not always in the same office as prevention for HIV. So it's really, really complicated. And then that filters down into the actual nonprofits and the services themselves. And what we need ideally is coordination that would operate under an integrated or unified strategy from, laterally among each of these levels, but then also, moving horizontally back up and forth in terms of data sharing. And right now, I see, right now people are really trying hard to fit this together, and fit all these pieces together. But, what seems to be lacking is that right now we don't really have a unified integrated strategy, and that's a complicated factor. So at the different levels, we need to, do our part to try and, sort of braid together what these funds are to make sure that we're getting comprehensive services to the people who are actually using drugs. So on to the next slide. That's what we're talking about today. Is it's really about funding, and collaboration within funding, right? I often like to think of the funding that SSPs, the way we are trying to fund SSPs as really being a braided funding stream, right? If you go to the next slide, you'll see this one assumes that we have funding strategies and sort of a bigger unified strategy. But ideally what we want to have at this point, because all of these different federal organizations, agencies, basically are trying to piecemeal together different parts of this program. So injury prevention is working with overdose prevention and putting that down into states, and they're able to fund certain parts of certain components. HIV is able to fund certain parts. HRSA is able to fund certain parts. And what unfortunately is falling to the onus of both programs and states right now is how to figure out that braid, right? If you go to the next slide, we see, what we think of as being some of the potential strings in that braid. HIV programs, injury prevention, behavioral health, substance use prevention, HIV, chronic care. I mean, all of these are potential sources of money, and folks that all should be working together to figure out how to make sure these programs are adequately staffed and can provide services that meet the needs of their communities, right? So the next slide kind of gives you a quick table of just some of the most recent and currently existing programs and different grant opportunities that are provided within each of these different, from each of these different agencies. And this is really just kind of a small smattering of what is potential to fund some elements of these programs. And what we could really do would be like much more strategy from the top, and then much more strategy about, making this less of a puzzle, right? So just to give you an idea there. So on the right, you see SAMHSA. And right now, like I said, SAMHSA funds are being used in some states to support elements of SSPs or support the programs all, sort of straight out. But the next slide I'll show you, SAMHSA money, and it's partially because, politically, I think, that politicians like that prevention and treatment thing, right? So they give a lot of that money, the opioid response money, to SAMHSA. So the money that SAMHSA gets really dwarfs a lot of the more traditional HIV, infectious disease, public health money. So on the next slide, you'll see sort of a breakdown of the allocations for the opioid state targeted response. This is the SAMHSA money, right? This is 2018. You're looking at, in the lightest states that get the least money, about $2 million, right? All the way up to about $45 million. Really just like kind of staggering numbers here that, like, even in my wildest dreams, I just can't even imagine how you'd spend that much money on prevention and treatment efforts alone. So if there were more coordination at the state level, at the federal level, we could really kind of, put a shot of really much needed funds into working within that gray area, working with SSPs and people who are using drugs actively. So the next slide shows you a breakdown of sort of SSP funding historically. This is from the Day Purchase Memorial Survey on National Survey on Drug Use, National Survey of Syringe Exchange Programs, and that historically we see that the vast majority of SSP programs have been funded through private foundations, right? They've always carried that burden, and we have always been so grateful. And ideally, when we think about, 17 million, if you compare that to the 45 million that SAMHSA gives some states in 1 year, we could really think about just, how expansive and how comprehensive our programs for folks and using SSPs could be, within SSPs could be, right? And so just to kind of put a plug out there. And then this next slide kind of gives you a quick rundown of the different, kind of off the top of the head, the major players about what foundations are funding SSP work. So you see the Comer Family Foundation, the Elton John AIDS Foundation, MAC AIDS Fund, NASN, Syringe Access Fund from AIDS United, and then there are other more local funds that come into play as well. So a lot of local foundations, a lot of local public health nonprofits, research foundations will fund, community health worker foundations will fund elements of SSPs, or they will couch, SSPs within a larger hospital or a foundation within a hospital. The thing to note about a lot of the more national players, especially, some of the bigger ones, is that, historically they tried to fund the nuts and bolts of SSPs to really help people make ends meet, to actually get services and supplies in the hands of people who are using drugs. And they're definitely still doing that. And I think, unfortunately, what we do see is a slight shift for some funders to start focusing on funding things that are really innovative, as opposed to just sort of the nuts and bolts of the program operations. And so, funding things that are, great, but also we just need to make sure that we are, making sure that the programs actually happen, and that the nuts and bolts are still being funded. So, so that's really important to consider there. And I know I'm out of time, but I only have one slide left. So the next slide really kind of goes into, when we think about braiding these resources, when we think about applying for determinations of need, when we think about trying to craft our programs so that we are sure that they're meeting the needs of the communities in which we serve, a big part of that is about being willing to, and wanting to ask for help. And Moya gave a great rundown before of sort of the capacity building network and the capacity building assistance that both New York City and NASTAD provide. And really, this is a process of sort of CRIS requests, which is capacity building resource information something requests. But this is basically just a really simple process that any state health department can request from NASDAQ or request through New York City. And we basically tailor, this is the part where we get to help you troubleshoot programs and provide trainings that you've identified as being necessary and important. And so, you know, I encourage anyone to reach out to me or to Moya if you have questions about that. We can always help you submit those forms. We can always help you provide technical assistance or capacity building trainings, all different kinds of things as moving forward. And it's one of the coolest parts of my job, in fact. It's one of the parts that I love the most, because I really appreciate getting to work with states and really getting to help with you all who are doing the work on the ground. And then NASTAD also provides a lot of other types of resources that we put out. If you have questions about state level policy, I have a quarterly drug user health call, conferences that health departments in particular are geared towards those folks in particular. You know, we're always here to be creative and help you out as we can. So the last slide is just my contact information. I will hand it over to Lauren.